I'm discussing around 80 questions that came in Neet SS 2025 in respiratory medicine. HIV positive male presenting with pneumonia, most common cause is Streptococcus pneumoniae. Legionella pneumonia can be present in HIV patient, but that is not the most common cause. Wrong about ensifentrine. Ensifentrine is given inhalation. COPD patient presenting in acute exacerbation, intubated, suddenly developing tachycardia, hypotension, difficulty triggering breaths. On bedside ultrasound examination, B lines were present, lung point was absent. So what will you do? The correct answer will be disconnect the ventilator as the patient is developing autopsy. Other correct options would have been decreased respiratory rate, decreased in IE ratio, and decreased tidal volume. Young male presenting with bilateral hilar lymphadenopathy, fever, and fatigue. So the question was, which haplotype are you relating with the disease? So the disease is sarcoidosis. Haplotype will be HLA-DRB1 1101. Which mediastinal lymph node station is not accessible by EBUS? Answer is station 5. Flat line on capnography immediately after intubation signifies that it is an esophageal intubation. Formula for static compliance is tidal volume upon P plat minus P. Patient on warfarin presenting with hemopsis, so we will supplement with prothrombin and vitamin K. Young male presenting with complaints of recurrent oral and painful genital ulcers. Now complaint of recurrent hemopsis. On CT it was found that the pulmonary artery was dilated. What will be the diagnosis? It will be Behçet syndrome. End-stage renal disease patient planned for a transplant. On CT chest, it was found that the patient has diffuse calcified pulmonary nodules. What will you do? So the answer is do nothing, as it is a case of secondary metastatic calcification due to CKD, which happens due to secondary hyperparathyroidism. Patient with CHF presenting with bilateral pleural effusion. Upon examination, it was found that one side had transudate while the other had an exudate. So it is called Contarine syndrome. Pregnant female who recently gave birth develops amniotic fluid embolism. What will not be expected? Answer is high grade fever. 38-week pregnant female develops pulmonary embolism. Patient is now planned for induction. So anticoagulation of choice will be unfractionated heparin. Order of vaccination, it is PCV13 followed by PPSV23 after 1 year. Pregnancy related changes, the FRC decreases. Bogdelic hernia is posterolateral in position. Morgagni hernia is anteromedial in position. SLE patient, most common pulmonary complication is infection or bacterial pneumonia. Most helpful marker in diagnosis of SLE pleuritis is pleural fluid Na titers. The pathophysiology of pulmonary hypertension in sarcoidosis is pulmonary fibrosis more than granulomatous infiltration of the arteries. Most common lobe involved in bronchiectasis is left lower lobe. Young male presenting with bronchiectasis on examination had low immunoglobulins. Diagnosis is common variable immunodeficiency. Patient with acute severe pulmonary embolism. What will not be present in physical examination is parasternal heave. Xylophilus disease is due to exposure to nitrogen dioxide. Cafe spots, Lisch nodules, and inguinal freckling is seen in neurofibromatosis. Patient with von Recklinck's disease found to have right paratracheal mass. Possible diagnosis is neurofibroma. Fallen lungs is seen in bronchial rupture. BHD syndrome is associated with mutation in FLCN gene. Patient on continuous oxygen therapy complains of increased watery discharge. What will you do? Answer is saline nasal drops. ILD seen in ankylosing spondylitis is apical fibrocystic disease. Middle-aged male presenting with fever, night sweats, anorexia, weight loss. On examination had leukopenia, hypercalcemia, and bilateral hilar lymphadenopathy. CT showed perilymphatic and peribronchovascular nodules. On TBLB, patient was found to have soft granulomas. Answer is miliary TB. There is no significant difference between mortality or hospitalization rate in 15 hours to 24 hours of LTOT as per redox trial. There was a waveform showing auto-peep. Answer was decreased respiratory rate, decreased IE ratio, or decreased tidal volume. RTA patient presenting with hypotension, tachycardia, tachypnea. What will you do? Answer is insert ICD, tube thoracostomy, in view of pneumothorax. A patient on HFNC is on support of 40 liter per minute and 0.4 FiO2. What will you do for weaning? So the answer is decrease flow rate by 10 liter per minute. Patient with central sleep apnea found to have high AHI, and the central sleep apnea events were very high in this patient. What to do in this patient? There is a table in Fishman which gives BiPAP with backup rate as an answer, but according to guidelines, the treatment of CSA is CPAP. Cough syncope is more in males because of more negative intrathoracic pressure created, which decreases cardiac output and causes cerebral hypoperfusion. Patient with thickening of skin of fingers with capillaroscopy showing capillary dropout. Answer is SSC. Now a mode of ventilation. What is wrong about it? So answer is patient and ventilator pressure is equal to transpulmonary pressure. Highest risk of TB in silicosis is in chronic and accelerated forms, least in acute form. SSC is associated with exposure to silica. Primary indication of VV ECMO is acute hypoxemic respiratory failure. Least failure rate of an IV is when applied for cardiogenic pulmonary edema. A case of chronic mountain sickness. So what will be the definitive treatment in this patient? Answer is bring the patient on lower altitude. Rheumatoid arthritis with cricoarytenoid joint involvement. What will be the most clinically significant finding? So answer is variable extrathoracic obstruction on PFT. Patient with vagus, not having ANCA positivity, not having renal involvement. What will be the treatment for remission? Answer is IV methylpred. Patient with hearing loss, nasal crusting, recurrent hemopsis, being suspected for some disease. What will you test for? Answer is ANCA. Subsequent lavage taken in DH will be more reddish in color and the hematocrit will increase. 19-year-old male presenting with complaints of recurrent hemopsis also gave history of trichoptis. CT chest showed interior and middle mediastinal tumor. Answer is teratoma. Cobblestoning or pavement appearance on CT scan with hypoxemia. Answer is pulmonary alveolar proteinosis. Trachea and bronchus of an HIV patient reveals reddish, bluish patches. Answer is Kaposi sarcoma. Worst prognosis of IPF, young age. Lung transplant. What is an acceptable risk factor for the recipient? History of HCV in donor. In case of hepatic hydrothorax, what will be the definitive treatment for this patient? Answer is liver transplantation. Drug of choice for AML alpha mutation is crizotinib. Contraindication of TPT is chronic hepatitis. Replacement sequence for H-resistant TB resistant to paracetamide. Replace it with linezolid. Monoclonal antibody indicated in ABPA is dupilumab. Another question relating to dupilumab was alpha receptor blocker, which is dupilumab. Another question had dupilumab is used in chronic bronchitis with increased exacerbations. Not a trial of IPF is impulse trial. Pneumomediastinum presenting complaint is retrosternal chest pain. Correct about chylothorax is pleural fluid triglyceride upon serum triglyceride ratio is more than 1. Drug of choice in idiopathic pulmonary artery hypertension is nifedipine. Recurrent breathlessness, a patient taking SOS salbutamol since childhood, higher total IgE of more than 1000 and increased specific IgE for Aspergillus fumigatus. Answer is add itraconazole. A sandblaster of 15 years having increased breathlessness, CT scan showing centrilobular nodules bilaterally with left lower lobe consolidation with possibly cavitation. Diagnosis is TB. Absolute contraindication of NIV is fixed upper airway obstruction. Anti-CCP and ILD correlation. Increased titers is associated with increased risk of ILD. Female delivered 2 days back. Now wants to travel. What will you advise? So no air travel for 4 weeks is the answer. Castleman's disease is associated with HHV8. Triad of 4 histopathology is seen in IPF. Steroids when are contraindicated in severe COPD. Answer is eosinophils less than 100. IV monoclonal antibodies restylizumab. Structure present in all compartments of mediastinum is lymph node. Slow growing non tuberculous mycobacteria is Mycobacterium avium. Lifetime risk of conversion of latent TB to active TB is around 10%. Panda and lambda sign on gallium scan is seen in sarcoidosis. Arthritis, bilateral hilar lymphadenopathy, and erythema nodosum is seen in Lofgren syndrome. Onycholysis is seen in yellow nail syndrome. Single most important epidemiological indicator of TB is mortality rate. According to WHO, impact of lower detection is more in mortality associated with TB because impact of lower detection on incidence rate is delayed. If you know any more questions, please post in the comment section. We can discuss them there.